is cardiologist Dr. Scott Murray.
Thanks, Sam. Thank you. Okay, guys, thanks for hanging about. And you should have finished on that last talk, because that was inspirational. That's fantastic. I'm only going to take things a bit downhill, I'm afraid, because talking about the heart and talking about cardiac problems, possibly not the way to end the day. I want to end on a happy note, but we'll see how this goes. Now, does anyone, I've put these pictures up, does anyone know what this thing on the left is here, this image? Does it, just shout out if you know what the image is. Well, yeah, do you know what it was used in? Yeah, so it was used in a public health sort of thing to suggest that you shouldn't ignore chest pain, you should go and get seen to. And it just highlights, the reason why I use it is that it highlights the impact that sometimes public health messages get mixed up with populations, because we had a few people come to A&E with a belt around their chest saying I had chest pain and I used the belt didn't work, so I've come here. So you have to be careful what you say to people, because it can be interpreted in the wrong way. So it's just a little note. And this image on the left here is an interventional cardiologist doing a self-portrait. So I want you to get into the mindset of cardiologists. So hopefully, so we've got some learning objectives here. I want to give you the background, the problem, potential solutions, and some questions. Now, I'm passionate about this slide. I use it in all my talks, and it's because the human race, we have a bell curve distribution of things that we can measure. And the problem is that guidelines, societies, keen to push everything towards making people unwell as far as the guidance goes. So like the latest blood pressure guidance, if you're not 120/80, you're hypertensive. And I think that when you look at the data, the meta-analysis, so forth, well, you start to get disease over 140/80. So I'm not saying that it's wrong, I'm just saying that we're medicalising people to a certain extent and possibly pushing too hard. But there's no doubt that we should be looking at why people are falling in the river. And that's something that didn't really cross my mind when I was a cardiology trainee. I was just pulling people out of the water when they were drowning. So I've been on a personal journey. I took a blue pill, went down the rabbit hole, and it's been interesting. So I've got David, Ivor, Ted Naiman, a whole Professor Noakes, a whole load of people to thank for ruining my career in interventional cardiology. So this is what we do in interventional cardiology. There's a narrowing in a big pipe, and monkey see, monkey do. Brainstem reflex sort of intervention to make that pipe look wider. And this is the moment I handed over to my colleague, Dr. Haselden, who's another consultant, and said, "This is yours now, you can carry on, I've had enough." Because essentially, what you're doing is you're putting lipstick on a pig. The entire artery is diseased from top to bottom, and we are focusing on a bit that's narrow. And you can stent that narrowing, yes, you can improve the blood flow, but the rest of the artery is still full of plaque. So this is modern cardiology at the moment. This is cardiology dog. It's barking up the wrong tree, focused on fancy things. And we've got a situation where guidelines are driven by big device companies and pharmaceutical companies, because they're the ones who can afford the massive amount of money it costs to run these trials. And those trials get into the guidelines because they're big randomized controls trials and lots of patients. So obviously we're going to use that information. The problem is the education is tainted by this, and occasionally it's more marketing than substance. And the key opinion leaders, myself included, we get approached by pharmaceutical companies to do talks or be involved in advisory boards, and then they become your paymasters. So it's a difficult situation to be in. Often these interventions have limited absolute risk reduction, and the number needed to treat is high. It's a sick care consumption model, and money talks, unfortunately. So various bodies in the UK, Public Health England, British Heart Foundation, ESC, have all released guidance on what we should do to prevent cardiovascular disease, because there's a burden there. Despite the guidelines, despite the statins, despite everything we do, we still got 1 in 4 people having a premature death from cardiovascular disease, so we still have to do something about it. And we know what the risk factors are, but there's a whole load of things that most people know: blood pressure, cholesterol, being physically inactive, salad dodging, as I call it. But there's a whole other social and environmental factors that we don't pay a lot of credence to, and those are the things that we need to tackle if we are going to have some sort of impact here. And that's the difficult stuff. Now, we can't ignore the fact that cardiovascular disease is declining, okay? And this is up to 2013, that total mortality has declined. But it's still the leading cause of death in perspective. And I really like this slide. I use it a lot because there was a signal here, and this is Unal B, its circulation in 2004, showing data up to 2000. And you see at the top here, we weren't heeding this notification. Things had got better, smoking's going down, people aren't, throw out their chip pans with the vegetable oils, and things got a bit better with the low-fat message. But there was a lot more deaths from diabetes, physical inactivity and obesity. I started to see those signals coming through, and now Washington Post released 2016 that US life expectancy is actually decreasing for the first time. And this is in heart disease. So what's going on here? We've done so well, we're improving, but now is the trend changing? Are we bottoming out, and are things going up? And you see here, if you look at the data between the United States and UK, this is if trends continue, the red bars. This is if we were a 1% BMI reduction, and this is if we were back at 1990s levels. I mean, you've got to love the 90s, that's when I was a teenager, so we would be doing a lot better if we were back there. So is it anything to do with the fact that we continue to live in this society? Louis Armstrong would be turning in his grave. We're not living in a wonderful world. This is a billboard ad in America. You drive under this, and it says to me subliminally, kill yourself. I think that's what it says. I'm sure you can agree with me that we're unfortunately subjected to these sort of things in the environment. And this is what the patient's worried about, worried about what's in the Daily Mail or the Daily Express or however you want to frame it. But you can't get away from the fact that, obesity, tobacco and alcohol cause more deaths than many things, and that probably diabetes is worse than ISIS. So we can always rely on, independent coaching events to tell us to move more and consume less. So this is from Salim Yusuf's original study in The Lancet called Interheart, and these are the reasons why people have heart attacks. And we know that 80% of this is preventable, but the problem is that there are bodies that are focusing on fighting for every heartbeat. I won't name individuals, but we know what causes heart attacks. We don't need to know if a protein drops out in a mouse model. We actually need to mobilise these, focusing on these risk factors. And if you look at Interheart and you look at the population attributable risk, the biggest thing was ApoB over ApoA1, so lipids in the blood, to put it down. But what we see, and I've got to thank Ivor for reporting this and putting me in touch with this sort of thing. If you look at Interheart, you look at ApoB to ApoA1, why is it so important? Because it actually reflects what's going on metabolically in the body. And this is another study showing that if you're insulin sensitive versus if you're insulin resistant, the changes that you see across men and women in their cholesterol metrics are significant. And the reason why the cholesterol's gone off is because metabolically the patients are being shot down, and their liver is not doing what it should do physiologically. Insulin, when it's released, should actually tell the liver, okay, that's enough, no more cholesterol, stay within the boundaries, everything will be fine. But when you become hyperinsulinemic because of insulin resistance, the liver actually gets stimulated by the increased cholesterol. So there's a really good paper on insulin resistance and hepatic insulin resistance that tells us this. The HMG-CoA reductase thing that statins inhibit actually gets stimulated by insulin in these adverse conditions. So that's why people are making more cholesterol. So when I see patients now with high cholesterol values, I start to think, what's metabolically going on with this patient? You know, don't just simply reach for the statin prescription, which may or may not be warranted in some cases if you've had a heart attack, but not in all. So this statins for all is wrong. We need to be starting to think about why. And here's one of Ivor's finds from the European Heart Journal, looking at ApoB increasing ratio and the risk of insulin resistance. So these problems that we focus on, high blood pressure, cholesterol, hypertension, they're all diseases of problems with the metabolic homeostasis of the body, but we don't focus on that. We say, oh, we must give you a pill for the blood pressure, a pill for the cholesterol. And we know we don't control these risk factors, so it used to be 50-50. 50% are diagnosed, 50% actually have control of that parameter. And it's even worse than that. You know, you've got people here, obesity on lifestyle treatment, actually achieving a BMI and waist circumference goal, 3%. So it isn't a rule of 50 and 50. We're struggling, and we're struggling because we're not tackling the root cause. And we've got people like Professor Noakes and Gerard Reven and all these other people who've gone before to try and highlight this. This is 1996. We're still not doing it because we already know the killer. The killer is cholesterol, and we just need to get enough evidence to prove it. So it may be cholesterol, but the cholesterol's gone up and everything's gone out of whack because your insulin's gone wrong. The other thing we need to focus more on is how sugary patients are. What's the glycemic impact on disease? And you see here from the EPIC Norfolk cohort, 4,500 patients, that A1C directly correlates with coronary events and mortality. So that's why we should be looking at this. So some of us know what we're doing, but not everyone does, and that leads to problems. So, okay, I'm going to move on to the problem. Now, Ted Naiman produces these amazing infographics. If you don't follow Ted Naiman, you should do. And he's gone through this thing about obesity, saying, is it carbs, is it fat, is it calories, is it insulinogenic food? Is it frequent carbs and fat, see obesogenic rat chow? And this thing about glucose displacing fat oxidation actually stimulated my interest. And I thought, what is going on here? But then when you actually look at it, is it carbs, is it insulin, focusing on one thing, it's never right. You know, we end up with our confirmation bias takes us down a little journey, and then you realise that there's probably about 50 or 100 other things that you can't account for, and there's no way you're going to be able to sort of sort this out. And this is what often you do when you're looking up things on the internet, you know. Wow, suddenly I know this is all coming together now. I've worked it out. But then you have to just take a step back and think, hang on a minute, I need an expert, I need someone else. So we in Liverpool have set a strategy in motion about cardiovascular disease prevention. And the interesting thing that I want to share with you is the data from Liverpool. So we see here that actually coronary heart disease is decreasing. We're getting less cases in Liverpool, but we're seeing an explosion of atrial fibrillation, heart failure, hypertension, and subsequently stroke because of those. So they're going up and coronary artery events are going down. Why is that? So people come to my clinic and they say, you know, I've got a family history of heart disease. So a bit like Simon's first slide with no one running in your family. It's because it's not just the genes, it's the environment and the cues. You know, what do you eat for breakfast, what do you eat for lunch, what's expected of you. All of those things play into this mix. It's not just the genetics. And this paper from Circulation highlights that. In 2011, they said that they researched patients to see how many actually achieved what they said was a healthy individual, and the rate is 1 in 1,000. So when we look at Liverpool, we've got 76,000 people living with CVD, and you see here the biggest contribution to that is hypertension. And we, people here, know that we can do something about hypertension that might not involve pills. Has anyone seen the film WALL-E? Yes. For those of you who've seen it, I've tried to get a video, it's very difficult, but the human race are in space because the Earth is trashed, and they're all sitting on their little scooters with their iPads, having their drinks delivered to them, and no one can stand up. But I mean, unfortunately, in some areas, if they put iPads on the scooters, we're in big trouble. And if they can deliver food. So this is where we should be looking. Adipose tissue, sedimentation, lack of muscle mass. This is where things are going to go wrong. So I want to put it to you that this is an image of a healthy heart, but it's not, obviously, it's on the slab. and he was a healthy individual who died not of heart disease, unfortunately. But this is what the heart should look like. There should be a little bit of fat around the coronary arteries, and this is visceral fat. This is an unhealthy heart, and I want to talk to you about this because this is what we're seeing more of. So this is a patient of mine, and when patients come into the room, immediately look at their tummy now. Don't look at mine because I ate some carbs yesterday. And I get patients come in who are fat, but they're big and flobby fat, and you poke it and it's quite flobby, and they don't tend to be as ill as some people who come in with the jeans down, my 34 waist, but then the tummy comes in, it's about 42, and it's hard when you poke it. I go around poking people's tummies in the clinic now, and instead of putting stents in, I now poke people's tummies and ask them what they eat. But this is interesting because I said to this chap, you're breathless. Why are you breathless? Why do you think? And we got an echo in the clinic, and this shows the echo report. His left ventricular systolic function is normal. Okay, so it's pumping fine. But there's this thing called diastolic dysfunction, abnormal relaxation, and a bit of a mild valve leak. Global layer of adipose tissue seen. So we're starting to see patients come in with this layer of fat around their heart. And this is what he has is the start of something called heart failure with preserved ejection fraction, if you haven't heard of it. It's called huff puff. So the patients tend to be huffy and puffy. And there's a picture of Arnold Schwarzenegger. That's just to remind you that they're normally older, a bit chunky, and the heart muscle gets a bit thicker. Okay, so that's why I'm using Arnie there, because he's instant. I think he's had 2 bypasses now, has he? Anyway, but this is what happens to the heart, and it's driven by those old chestnuts: obesity, diabetes, hypertension, deconditioning. We might know what pertains to that. And what happens to the heart is it gets a little bit thicker, a little bit hypertrophy in most cases, and this leads to these problems here. So I'm interested in this because I'm seeing more and more breathless patients in the clinic who have normal pump function but abnormal pump relaxation. And this is the things that are linked with heart failure with preserved ejection. That's what I'm calling this future heart syndrome, or what I see is happening. They have more evidence of atrial dysfunction, so more AF, and that's why we're seeing the increase in atrial fibrillation. They have autonomic dysfunction, vascular dysfunction, blood pressure's up. They get this dynamic valvular leak back to the lungs. So when they pump, some blood goes back to the lungs say, hey, I just gave you that blood. I've put oxygen in it. I want rid of it now. And you're giving it back to me. So the lungs get a bit under pressure, and then you get breathless easier. And where is it all coming from? So this is what's going on. This chap that I saw basically had this problem with his lifestyle. He's sedentary, but he's eating the wrong foods, eating way over his calorie requirements for his basal metabolic rate. And this leads to, as Ivor calls it, wheels off the wagon, metabolic dysfunction. And it's a bad thing, but it can be turned around by intervening here. But if you get to that point where you've got adisopathy around the heart, that has direct pathogenic effects on the myocardium, but also the coronary arteries. And you're sending out inflammatory markers and vasoactive peptides, and that's leading to other instabilities within the vascular tree. And so you can see that this HFpEF, huff puff, whatever you want to call it, breathlessness, it's centred around this, with a problem with myocardial fibrosis, advanced glycation endpoints. You get activated inflammation, altered gene expression, mitochondrial dysfunction, and you're going round basically in a cycle where you're going to end up with a big problem. Why is this? Why? I've started thinking about why. What's happening at the cellular level with those little mitochondria in the cell, the little battery that produces the power? So this led me to this, what happens when you're a fetus and when you pop out. So when you're a fetus, you basically rely on the mother's supply. So you can do most, you're running on glucose mainly, but when you come out, the fetal period, you switch to fatty acid oxidation. And previous studies have shown that if you go on in the future to develop left ventricular hypertrophy or a thickening of the heart muscle, your heart switches back to be reliant on what you were like as a fetus. So it goes back to glucose, and it wants glucose instead of fat. And the reason for that is it wants it because burning glucose is actually more efficient. You need less oxygen in the environment locally, and those heart cells that are squashed and a bit hypertrophied, they will work better if they're being given that substrate. So I want to say that controversy for me as a cardiologist, the heart, realising that the heart actually wants fat, it wants free fatty acid as its fuel. And although it can run on most things, it's omnivore, it could run on lactate, it can run on ketones, could run on glucose, because it has to keep working. This is something that we don't pay credence to. And under normal physiological conditions, the healthy adult heart, 60 to 70% of its energy from beta oxidation of long-chain fatty acids, the remainder from carbohydrate sources of glucose. So it wants free fatty acids to run efficiently. The problem is, in heart disease, when it makes that switch to wanting glucose, is that the GLUT4 receptors go in the ascendancy within the tissues, and the receptors for free fatty acids and beta oxidation go down. So the heart then starts to need more of that and get stuck in a bit of a negative feedback. So this is the paper from Circulation showing that fatty acid oxidation enzyme gene expression is down-regulated in the failing heart. And that made me think about, well, what about a lifelong low-fat, high-carbohydrate diet? How does that affect the mitochondria in your heart when there's a substrate that's coming in all the time? What about hyperinsulinemic patients or insulin-resistant patients? They're the perfect environment, hypertensive. The hyperinsulinemia is telling the cells not to start any lipolysis, not to break down. So you get to a point where, unfortunately, the heart is stuck in this situation in a diabetic model, for instance, a metabolic syndrome model, where there is abundant glucose, there is abundant free fatty acids, there's abundant fat around the heart and perivascular tissues, but it's actually locked into a cycle that it can't get out of. And it's almost starving in a sea of substrate excess. And that, I tried to come up with an analogy. The only one I could come up with was stimulated by something Ivor had said, and obviously my good friend Campbell has an analogy that I'm going to use. But does anyone remember old cars, petrol cars? So you got in the car, you went to start it, and if it didn't start, you pulled the choke out and pumped the accelerator, and eventually it spluttered into life, and you dare not push the choke in because it would just die. And what the choke was doing was basically choking the air supply to the engine and increasing petrol, or as I've put, glucose. So that's getting more substrate being sucked in. But if you drove with the choke out and revving the engine high to keep it going, ultimately you're going to have higher emissions, decreased life of the engine. And I just thought, is this advanced glycation end products? Is your engine coking up the fact that you've just got AGEs, and that's why the heart's stiff and fibrosed? So this is the best one I could come up with. And I had to Google a choke. The fact the revs are off the scale there to get things going. But this is something that Campbell's used to explain things to patients. I think it's excellent. So here's what you should be doing. There are plenty of patients come into my clinic who are a fatty acid supertanker. They've got everything on the body, you could fuel them for weeks, but they can't tap into it because they're constantly running on what they're feeding into the face. So this is what they want: low revs, beta oxidation, long chain fatty acids. But if you have to use the glucose, that's okay for a bit of a sprint or something. But then obviously, if you get stuck in that paradigm, you end up with the Ted Naiman stuff, blocking fatty acid oxidation more, down-regulating those receptors and increasing more storage. So if you don't burn it off, you're actually storing fat rather than burning it. And then you end up, if you're on the glucose again, you're having to pull the choke out and rev the engine. So this is Ted Naiman's slide talking about making fat and burning fat, and the fact that at the mitochondrial level, if you've got too much glucose around, that's what actually decides whether you're going to be able to oxidize fat or not. And this is why I think these patients are getting into that problem, because there's you're not making enough insulin to overcompensate for the tissue resistance in the liver and elsewhere, the muscle, the adipose tissue, but you then have got abundant free fatty acids and abundant blood glucose, and the heart is like, whoa, what is going on? So what are the solutions? So I want to talk about this drug, MPEGlift. It was studied in the MPEG trial, and the cardiology world is going mad for this. It's an SGLT2 inhibitor, sodium glucose transport inhibitor, and it's recommended early in the ESC guidance for diabetics. Why? They don't mention sugar, by the way, in that guidance at all. Low-fat diet. So SGLT2 shifts the whole body metabolism from glucose to fat oxidation. 2 and 4 weeks of treatment reduce the respiratory quotient and indicate a decrease in glucose oxidation, increase in fat. It's ketogenic, this drug. It raises LDL, but it lowers cardiovascular disease and mortality. So now they're all sitting back thinking, hang on, this drug saves lives in heart disease, but raises LDL. Now there's a lot of people scratching their heads on that one in the cardiovascular world. How can we sell this story? Okay, so I think glucose oxidation goes down by 60, fat oxidation goes up by 20. So we know the heart can run on ketones, and I think this is the closest the pharmaceutical industry can get to a low-carb, higher-fat diet. But they don't mention that at any point in any of the stuff. You give the drug will sort it out. So in diabetes patients with existing cardiovascular disease, the use of an SGLT2, substantially less than CVD and total mortality, heart failure hospitalisation without adverse events, it should be considered early. So we need to identify those that are at risk, okay? So either people need to grow to 7 foot tall, or we need to start having a think about what's going on. And this is another excellent slide that I've borrowed from Ted Naiman, showing that, you know, waist circumference is related to insulin resistance, and you need to really stop filling the adipocytes as much and stimulate the mitochondria. And how do you do that? You maximise the nutrient density in your food, you minimise the glycemic impact, you keep insulin going, but you want it to be within that reference range so that it does its job, so that it tells the liver to switch off making cholesterol. But you still need it there, you just don't want it to be way out of whack. And obviously high intensity interval training or higher intensity exercise can improve your muscle insulin resistance. So we need to get the message to our kids, because you know, there's a bit of a lost generation. You've got to admit when you look around that, you know, there is a lost generation. And we've tried to do that in Liverpool. You know, Public Health England makes some mistakes, but they got this one right. You know, they have put out about breakfast cereals, and we latched onto this because the honey monster developed diabetes as well, and he's now having to inject insulin on the packet of sugar puffs, which is such a shame. And so we know the dietary risks. What can we do about it? In Liverpool, we've got 1 in 2 adults who are obese, 1 in 5 smoke, 1 in 9 are drinking at increased level, 1 in 4 fast food, and 2 in 3 are physically inactive. So we thought, we need to do something, and my first protocol was the hospital vending machines. Now, this is the vending machine outside the diabetes ward. This is a patient's bedside of mine, which, you know, I think he thought he was doing me a favour by having Iron Brew there, you know, get him with the Scotsman. But if you can't make it to the vending machine, we'll bring it to you. We will bring it to you, bedside. Why? And this is my favourite one. This is a 20-year-old who could not get out of bed because of autonomic disease, with problems with inappropriate sinus tachycardia, dizziness, postural hypotension. It's an absolute metabolic wreck. But this was his bedside one day. And the thing that just gets me is that this is all, killing with kindness, as I call it. They bring in stuff, don't they? Lucozade, because, oh my God, you're going to die in hospital if you don't eat. But someone brought them in an actual bag of sugar. Just in case. You're going low, just get a spoon, shovel it in. And you notice here that there's something else I'm going to talk about here, but, the Queen's stamp on the bag of sugar. Let's talk about that. So how do we tackle this? How do we tackle this structurally? I tell patients, don't give your money to the 10 corporations that actually control all the processed food in the world. This used to be the adverts. Get the babies on Coca-Cola. It's good for them. It'll help them to socially integrate when they're older. What? And we find out that WHO is using money from Coca-Cola to plug the budget. And that cornflakes were developed for masturbation avoidance. And that John Harvey Kellogg wanted people to put carbolic acid on private parts of people. I mean, come on. So I think this is the next goal for Sam and the PHC, is to look at these foods that are by appointment to HM the Queen. I've gone with the royal theme because of the wedding and all that. But the Queen has got a royal stamp on various things. Sugar, Cadbury's, Nestle, Kellogg's. You could go through it. These are by appointment to the Queen. These are really important foods and products. So we took the other view in Liverpool. We went for the brands and we named and shamed them. And we started with fizzy drinks, and then we went on to breakfast cereals. We've just done a stretch on yogurts. And there's a website you can log on to, savekidsfromsugar.co.uk. I can't vouch for this. I come up with some basic ideas, and the woman who did this, Sue Cummings, Liverpool Public Health, she's amazing. And she mobilised that team. In fact, I think she used to work for a FTSE 100 company, so she really did a massive job. And you can put in what your kids are having, and then you can work out how many sugar cubes they're having. And subsequently, BBC News reported on Kellogg's reducing the sugar in cereals, but they quoted the Liverpool report in this article. So we're really, really proud that maybe something that we did had a handle on this. But Kellogg's won't cut the sugar in Frosties because, why? It's an adult cereal. Iron Brew have responded. They've remade Iron Brew. And now everyone in Scotland's completely gutted because it can't cure your hangover. It was the go-to drink for hangover cure in Scotland. So what should we be moving towards? Is this what we should really be doing, public health, or in terms of structural interventions? Or should we just be recommending Krispy Kreme? Because that's how you could drive things. 50% fat, 50% sugar. Tastes amazing. Or should we be banning these things in hospitals? What's the right thing to do? Because for certain people, in fact, more than 50% of the population, this is the current Eat Well plate, especially diabetics. This is something we should be thinking about. And why do we struggle with this? I'm not going to say anything here, but, the Conservative Party conference sponsored by Tate and Lyle Sugars. And Jeremy Hunt's saying that obesity is a bigger risk than smoking. So we're the brand. If you go to the Public Health website, Public Health England, and the latest thing, 400, 600, 600, you can link directly to the McDonald's website. I've done this myself in research for the Liverpool stuff. So they say, what should you be able to eat? What can you eat? And you can link and choose your food. To do this, major retailers such as Greggs, McDonald's, Starbucks and Subway will be providing a range of options to help shoppers stick to the calorie guidelines. So you can go in and choose a meal under 400 or 600 calories. You can choose your main and your pudding. Is this regulation or is this legitimisation? Is this advertising? From Public Health England. Is there anyone from Public Health England in the audience? I've given this to my colleagues in Public Health England, and that's why this place is so important. They say in their document, sugar reduction, well, we want to cut yogurts to 11 grams of sugar. But in this website, you can go to Greggs and you can pick what you could have as a breakfast. 21 grams of sugar. How is that good for someone who is carbohydrate intolerant or diabetic? And we know from research that even if your fasting blood glucose creeps up above 5.6, that you're at risk. There's an association between prediabetes and risk of cardiovascular disease. And 1 in 10 of us are on a sugary, slippery slope. In Liverpool here, 30,000 patients with non-diabetic hyperglycemia. So in current advice, if you look at patients who are on a Freestyle Libra, about where their blood sugars are, what they're doing, and then you switch them to a low sugar, low starch, you see the complete difference. It's just like a flat line. And we've worked out in Cheshire and Merseyside with David's help that we could be saving 3 million per annum, and that based on Norwood results that we're going to be seeing benefits of reduced obesity, reduced type 2 diabetes and cardiovascular endpoints. Because if you lower HbA1c, you improve the chances of dying from a heart attack. So we're working with the GP Federation, but we've still got to break down the dietary recommendations at the moment. This is the ESC, low-fat diet. It does say sugar-sweetened beverages must be discouraged. But then you've got this issue where some fats are actually protective for diabetics, so the odd chains. And then you've got the issue that saturated fat in the blood is not the same as saturated fat in the diet. We can make saturated fat in our own bodies that will appear in the plasma from what your liver can do with de novo lipogenesis. So what are we measuring here? What are we recommending? Why are we doing that? I still don't quite understand. And there are bodies, Asim and various other people who've come through with, we should be obviously offering people a high-fat Mediterranean diet. JBS3, which is an official guidance in cardiologists' minds, doesn't go far wrong in that it does say refined carbohydrates, white bread, processed cereals, sugar-sweetened beverages, calorie-rich but nutritionally poor snacks should be avoided for prevention of cardiovascular disease. But in ESC guidance, it's all about just low fat, nothing about sugar. But then tucked away in the guidance, if you read it, there's this statement. Regular consumption of sugar-sweetened beverages, 2 servings per day compared with 1, a bit like David's Bermuda people, was associated with a 35% higher risk of coronary artery disease in women. Why do we not know that right from the start? And there are papers coming through now from James de Antonio and various other groups showing that postprandial hyperglycemia and insulin resistance, hyperinsulinemia is something we need to pay attention to. I don't think that the cardiology world and various bodies are at this sort of level yet. From the Volek, Feynman, Finney data suggesting that actually a high-fat diet can reverse coronary risk. We're not there yet. We want people to be there. We want to move guidance towards something that's palatable for everyone. We should be bringing this out in the open to discuss it, not suppressing it down and saying, look, what are the bad fats? What shouldn't we do? We shouldn't be frying in vegetable oil, I understand that. But what should we be eating? What are healthy fats so that patients can move forward? Because at the moment, they don't know what to do. They're completely and utterly confused. So I just say to them, if you don't find time for nutrition and a bit of exercise or nutrient density, thinking about what's going in, then you're going to have to find time for illness. And that's better the hard truth than the comforting fantasy. Carl Sagan. So, how do we improve? For me, I think it is about an element of carbohydrate restriction for these patients, but also doing some form of movement. Okay, I don't subscribe to the you can't outrun a bad diet. I say don't compete with what you eat. So the patient shouldn't be saying, well, I burned 1,000 calories today, going to go to Starbucks and nail a muffin. It's just, that's what I want people to avoid. I want them to move more, and I want them to think about, it's not just about plodding along on a treadmill. You need to get the type 2 muscle fibers going. So some form of high intensity thing, because if you get the type 2 muscle fibers and the mitochondria bulking up, then you're going to increase your basal metabolic rate, you're going to keep your lean mass, and that's going to be a whole healthier phenotype than just plodding along. And people say, I go out for a walk with the dog, but they're walking probably to the pub as well. The wife finds out because she takes the dog out for a walk and it takes her to the pub. So I think that there's something in this, and there are papers coming out. We can't knock the fact that metabolic risk factors decrease with regular exercise. I say to patients, train your heart to be resilient, train the inside of your coronaries to be resilient, so that if something happens, your blood pressure goes up, your heart rate goes up, your heart arteries can deal with that. The worst thing is doing nothing and then suddenly realising it's snowed outside and going out to shovel the snow. Or, as used to happen in Liverpool, the sun came out, the sound of 1,000 lawnmowers resonated in the air, and then suddenly the bleep was going off. Someone's getting wheeled in with an MI in his garden after doing too much gardening. So, I'm going to finish up now, and I'm happy for anyone to add or contact me with extra S's for this, but this is Scotty's several sins, sending sickness sometime soon. So you can see I like alliteration. So sugar and sugar-sweetened beverages, smoking, sitting, sedentation, sarcopenia, sick fat or adiposopathy, starch and cereal. Okay, I haven't spelled that properly. A sandwich subculture. It really irritates me when you go to, get something for lunch and you see people who are like, at the till, they're being coerced into getting a cookie because it's 50 pence cheaper. And, they're struggling, the belt's about to burst open. And I think this is just something we need to get around, these meal deals and buy a packet of crisps and blah, blah, blah. So snacking, Glasgow's favourite, salad dodging, stress, sleep deprivation, solitude and sadness. I think these are all things that fit into cardiovascular disease. So where should the money go? We've got limited resources. Personally, for me, it should go in cardiac rehabilitation because there's no device injury, no big pharma buck. We should be prehabbing all people who have either a sense of cardiovascular disease, a sense of insulin resistance. They don't look metabolically healthy. We should be speccing this up and rehabilitating patients because patients come to rehab after their heart attack and they say, why didn't someone tell me this 20 years ago and then I might not have had what happened to me? They make the changes after the event happens. We are up to 51% in the UK, and that's one of the best in Europe in terms of uptake now. But we know that cardiac rehab does these things. Can reduce mortality, can reduce cardiac mortality, unplanned admissions, quality of life, return to work. And this is the organisation that I'm president of at the moment. We've got evidence from big trials, Rod Taylor in south of England, there's Cochrane Collaboration data on this, randomised controlled trials showing what this procedure or intervention can do. An absolute risk reduction in cardiovascular mortality with a number needed to treat of 37, hospital admissions, number needed to treat 22, heart failure hospital admissions, number needed to treat 18. How many percentage of heart failure patients are we seeing? Less than 10%. This is where we are in cardiology at the moment. We're using drugs and procedures and things, and we've got this staring us in the face, and we're not funding it, we're not staffing it, and we're not paying credence to these numbers. But NICE will approve drugs, cost per quality 29. And an AF ablation for atrial fibrillation costs 7 grand, it's got a 50% success rate. Put the money where the benefit is. So if you want to look up the Cochrane Collaboration. So cardiac rehab is cost effective. Aspirin and beta blocker is the only thing that beats us. And it saves money for the NHS. If we could get the 65% of people into rehab after a heart attack, we could save 30 million. And there was a TED talk recently that I was really interested in. It was predictors of how long you'll live. And actually, the final graph, social integration, close relationships, stop smoking, stop boozing, cardiac rehab, exercise, lean versus overweight. That's, the top things. Cardiac rehab gets in there, but we don't fund it. We don't staff it. So these are my final slides. Life is short, and I think it's important that we explain to patients now about Healthspan, because people are living longer. And see patients in my clinic who have cardiovascular disease for 25 years. They're extending their disease span. It's no way to live. And we want to make sure that, lifespan, we minimise disease span by maximising health span, is what I say to patients, because before you know it, it's over. So I invite you all, if you want to come to Glasgow in October, we have a conference, BACPR. Some people from the PHC low carb world will be there, as they were last year. And hopefully I won't get too much grief about it from the old guard. So get in touch with ideas. I hope you found this helpful. Please feedback, and thanks for listening.